calculating possibilities. This might be the
Hey guys, good evening. Am I audible and visible? Sorry for the delay. Am I audible? Am I visible? Hello guys, good evening. So let's go to the one more class on inflammation MCQs part 2. So I have 8 MCQs, one-liner, one scenario based, again a one-liner and a scenario based, right? Hello Krishna, hello and hi, good evening live. We'll do the same thing, and from next class onwards we'll be starting neoplasia. I'll try to cover the entire neoplasia which is there in Robbins on RRR series. Even things which are not so important from a university point of view, because I want you guys to understand cancer, because I feel that you guys are the future generation. Hopefully some one of you will fight against cancer, and the basics of understanding them is very important, right? Let's go very slow and steady for neoplasia chapter. Ignore if it's happening in your college or not, doesn't matter. Please stick to it. We have to complete the entire Robbins neoplasia, right? Hello Pratna, hello Daya. With that note, let's go on to the inflammation MCQs part 2. As usual, comment on the answer, and let's discuss a little bit about the question and also the right answer. What do you guys think is the right answer? It's a simple one. We saw this yesterday as well. Dahiya started with option A. The most characteristic cell of a granuloma is, right? See, if you look at these options, fibroblast is actually not seen in a granuloma. I can easily exclude that. Endothelial cell is also actually not seen in a granuloma, right? So can you guys tell me what are the things which you would see in a granuloma? Whatever comes to your mind, what are the cells which will be involved in a granuloma? Epithelioid cells, yes, obviously I'll have epithelioid cells, or the activated macrophages, I'll have them. Do you have any of the inflammatory cells? You'll also have, yes, Jane cells also will be there. Like we said, option B is the right answer. Let's see what's the right answer. Also you'll have lymphocytes, primarily T cells. Okay? So these three are the one. Plasma cells, yes, not to that extent, but yes, I might see some amount of plasma cells whenever there's a little bit of B cell lymphocytic infiltrate, right? T lymphocytes, Jane cells, epithelial cells. These three are the most important thing for granuloma formation. So if you look at this, can I say that Jane cell is nothing but the union of activated macrophages? Is that statement right? Jane cells are nothing but union of epithelial cells, right? So the principal cell for me, or the characteristic cells for me, is epithelial cell. Jane cell is derived from that. I'm going to derive Jane cell from that. Jane cell is not the first cell which forms. Epithelial cell is the most important cell, and this epithelial cell is the one which is going to release your interleukins, which will bring my T lymphocytes also, right? T lymphocytes also is kind of a secondary thing for me here. My epithelial cell secretes interleukin 1, brings T cells, pushes them to Th1 pathway, and then it's the one which is going to orchestrate the entire thing which is involved in the granuloma formation, right? The principal cell or the characteristic cell of a granuloma is epithelial cells or your activated macrophages. Fine, it's not Jane cells. Do remember that, right? Let's see. This question looks big, but it's a very simple question. Read the question carefully. Look at the image. It's a very simple image, and let's see what's the right answer. Whoever is online, I want you guys to comment. It's fine if you make a mistake. It's completely fine. Whatever comes to your mind. Just 4 options, and one of them will definitely be right. So these scenario based questions are from Robbins review book. Robbins has a review book. So if you are completing any chapter, I want you to download the Robbins review book. It's a free book available as PDF. Please go ahead. They have amazing source of scenario based questions. Come on, it's fine if you go wrong. See, comment some answer. If you feel it is wrong, delete the comment. It's completely fine. But I want you guys to comment on the answer. Okay, still difficult. Let's read through the question. A 53-year-old person has experienced abdomen pain for 2 weeks. I know you guys are very early, but tell me, if there's an abdomen pain and there's a mild upper abdomen tenderness on palpation, bowel sounds are present, UGA scopy is found, and this was a slide. A patient with an abdomen pain, especially in the epigastric region, what disease comes to your mind first? I know you are young, but still, some of you might have had this symptom, right? An upper pain exactly here in the epigastrium. You have a pain here, tenderness there. What could be the symptom? This pain might change based on eating, drinking fluids and everything. Can anyone tell me what could be the probable diagnosis? Can that be an gastric ulcer? Gastritis? Possible? Okay, so with that note, I have a microscopic image of a biopsy of a duodenal lesion. Which of the following is the most likely pathogenesis here, right? Now let's look at this image. If you look at this image, here you're seeing the normal epithelium. Here also, I'm seeing the normal epithelium, right? Perfect, Patil. Welcome. So if you look at this part, can I say that there is no epithelial lining here? In this part, definitely there is no epithelial lining at all, right? So when I don't have epithelial lining, you call them an ulceration. Ulceration is a basic terminology. See, these are all very important for you when you go to your clinics. You have to describe something, a lesion. You have to look at an ulcer, right? So this is a classic image of an ulcer, most likely a duodenal ulcer, because the question says it's from a duodenal biopsy, right? So if you look at this option, definitely not an abscess formation, definitely not a granuloma, not a chronic inflammation. It is just ulceration, right? So P was right. So it's a classical picture of an ulcer, and this morphological pattern of inflammation is ulceration. I'm going to write few morphological patterns of inflammation. I want you to say, where do you see them? Acute or chronic? That is enough for me, right? You have a disease where the question says you have an suppurative inflammation or suppuration. What does it mean? Acute or chronic? Just comment acute or chronic, that's enough. Suppuration. Can someone of you help me? What does suppuration mean? I call something a suppuration when it is lots of pus, right? So when you have lots of pus formation, I call it suppuration. Perfect, Sunil. It is acute. Great, right? Okay, amazing. I'll add one more thing. I'm having a question which says it's acute inflammation, right? Which says there is serosanguinous discharge. A serosanguinous discharge is there in some random disease, right? What does serosanguinous mean first? What does the term sanguinous mean? Have you heard about a drink called a sangarine? You might have, right? Sangarine is red, right? Sanguinous means red. So if I have a blood mixed inflammatory exudate, right, I call it a serosanguinous discharge. So serosanguinous discharge, again, acute or chronic? What do you think of? You again think of an acute problem. Most of the acute problem, if the damaging force is little bit more powerful, it ends up in having a serosanguinous discharge. If you ever fall down around the second or third day, you will have some fluid coming out of it, of the wound, or you see, go to a casualty, see a patient, second, third day, you'll have a serosanguinous discharge. The entire dressing will become reddish in color, right? That is a classical serosanguinous discharge, right? Ashriya, okay? That also suggests of an acute inflammation, fine? Let's go to one more easy question. One scenario-based question, one one-liner, right? Kamran, hello, good evening. It's been a long time. So what could be the right answer? Bradykinin is for which of the following? Causes or which is responsible for which of the following? Bradykinin is an inflammatory mediator, and bradykinin's one of the main role is to initiate. Okay, Sunil has gone with B, Shreya has gone with D. Okay, great. I'm not denying that part bradykinin does that, but bradykinin is actually primarily involved in one of the important things. What is that? Bradykinin is one of the important mediators for pain formation, right? I'm not saying that bradykinin is not involved in vasodilatation. It's involved in vasodilatation to some extent. It's involved in vascular permeability also to some extent. But when I say the term bradykinin, I want to think of pain because that's one of the important stimulus which results in pain during an inflammation. See, because am I right in saying that histamine also causes vasodilatation, increased vascular permeability? Yes. Leukotrienes? Yes, right? So bradykinin is something which is directly involved in pain. So when you have any question saying what is the main function of bradykinin, I wanted to think of pain, right? Okay. Whenever you write an MCQ, right? Because I am not a person of mnemonic, read the hard way. It has to be remembered. That's all, right? Whenever you have any MCQ, I want you to remember this. MCQs are always choose the best option. It's never the correct option. It's the best option. Of these, for me to choose one, I'm going to choose pain. If there is a question which says more than one, go with vasodilatation and increase in vascular permeability as well. Fine. Okay. Great. Fine. So let's go to one more scenario based question. You guys commented for the one liner, right? I want you guys to please comment on the next scenario also. It is easy. It is not difficult. Fine. Okay. Read the question carefully and then let's comment. help you one by one, step by step in approach of this question, but just read the question and comment whatever comes to your mind. Okay, Kamran has gone with gamma. Anyone else? Sunil has gone with C. Come on, I want everyone here to comment. It's fine if you make a mistake, but just attempt it. Attempting KC. I'm not going to remember you. You're not going to remember me also, right? Perfect. It looks like lymphos in the periphery. Great, Kamran. Great. Most of you guys commented C, right? Now let's see the question. See, I have two things. Whenever you have a scenario-based question with a history and a microscope, I want you to concentrate on history, because as a diagnostician, every MBBS doctor is a diagnostician. My focus is the patient and not the investigation. I'm not going to concentrate on investigation first. I'll concentrate on patients first, right? I have a 43-year-old person who has cough and fever for the past 2 months. Okay, cough, fever for the past 2 months, and lung biopsies been done. Tell me whatever comes to your mind as differential diagnosis. Ignore the image. Ignore the options. Fever, cough for 2 months, and a lung biopsy is done. What could be the diagnosis? Probably. This is what you're going to do in internship. This is what you're going to do in the entire life. Perfect, Sunil. Can I think of tuberculosis? Is there a possibility? Yes, right? So if you started having community medicine classes, cough for more than 3 weeks with expectoration and fever, think of TB. That is by default. That's what your national TB control program says, right? Perfect. Now, I have a presumptive diagnosis of tuberculosis. You already know the theory. What will be the microscopic finding in case of a tuberculosis? Can anyone comment? You already know the thing. Just tell me what you think of microscopic finding of tuberculosis. Can I say granuloma? That's a simple one, right? Obviously, in the microscopy of tuberculosis, you are bound to see granulomas, right? Now, let's look at the image. Yeah, I know the diagnosis. You only said the presumptive diagnosis. You only said the microscopic finding as well. Now, it's difficult for me to identify this, but I'm going to mark one cell here. Tell me what that is. I want everyone online to comment. Tell me what is this? What do you think about these? What do you think about these? Whatever comes to your mind. I have two things rounded. What do you think about them? Can I call them a Jain cell? Perfect, right? So I know that there's a Jain cell here. I know that there's a granuloma here. Now, this part. Can I call these as lymphocytes? Small round blue cells? Obviously, they are lymphocytes. So whatever you suspected to be tuberculosis is right. Because in tuberculosis, you will have granuloma. And just now we saw that you will have your Langerhans type of Jain cells, epithelial cells, and lymphocyte in a granuloma, right? Perfect. So my diagnosis is right. It's tuberculosis, and the microscopy, I'm having granuloma, right? So this is the first half of the question. Now let's go to the second half of the question, right? Biopsy is performed, microscopic image is there. Which of the following chemical mediators is most important in the pathogenesis of the lesion? Question is asking which of the following thing is involved in the formation of granuloma? Answer is clear. It is interferon gamma, right? So interferon gamma is the one which converts your normal macrophage to an epithelioid macrophage, right? And this epithelioid macrophage is what gave the Jain cells and all the lymphocytes there, right? Perfect, right? So option C is the right answer. That's an important one in the pathogens of the lesion, right? Okay, perfect. Now I am going to link this to a real life thing. So can I say, I want you guys to listen carefully and answer yes or no. That's enough. Can I say a person who is suffering from tuberculosis, definitely the body will have granuloma formation. If the immunity is good, the body will have granuloma formation, right? Yes, no? Yes, Tushar, I'll do it. Just give me a second. Yes? Yes, perfect. So can I also say if that is true, the patient's blood level of interferon gamma will become high? Will become high? Is that statement right? It is definitely right, right? Perfect. So can I use a blood test for this patient to assay the interferon gamma levels and indirectly say, okay, there's probably a granuloma formation? Possible? Perfect. So why I am wanting this is, hello Lalit, good evening. Why I'm wanting this is, it's simple. Tell me which is easier, taking a biopsy from the lung or doing a blood test? definitely blood test is easier, right? So there is a test called as, remember this, quantiferon TB assay. It's called as a quantiferon gold test. So it's a quantiferon TB assay. It's called as a quantiferon gold test, right? So quantiferon, it's simple. It quantifies interferon. That's what quantiferon stands for, right? So I can do this test in a patient whom I suspect with tuberculosis. If I have a patient, Tushar, your question, had a cough with fever for 2 months, my first diagnosis tuberculosis. I can easily do a quantiferon gold test and tell that, okay, this patient's interferon gamma is more, so most likely his body is having a granuloma formation. We understand importance of pathology is not to diagnose in microscopy, to have the understanding of the disease. So you can decide which is best for your patient. If you know the disease, I can do it clinically, I can do it in between some blood tests for pathogenesis, or I can do it for microscopy. Fine, clear? So remember this, when you go to PSM, community medicine, this might come because this is one of the assays in for tuberculosis. When you go to medicine, pediatrics, OBG, orthopedics, because TB can affect any organ, right? That will be helpful. Fine. Again, we saw a scenario based question. Next one liner. Simple question. Answer. Simple one. Elastase. Wound contraction. T. Okay, fine. Let's see the question. We'll discuss about that a little bit later. We'll complete the class and we'll discuss about it. Fine. It's wound contraction, right? So this is, let's assume this is my normal wound. Can I say contraction means this? This is what contraction means, right? It's just getting contracted. That's all. Perfect. Of these four things, which you think will contract? Will an epithelium contract? No. Can a myofibroblast contract? Muscle, myo. Yes. Can collagen contract? No. Elastic tissue will have recoiling effect, right? It will not contract. Won't contract, won't contract, won't contract. The only one which can contract is myofibroblast, right? Only one which can contract is myofibroblast, right? So wound contraction is mediated by myofibroblast, right? So elastic tissue will have a recoil effect. So once I expand it, it will recoil. Elastic tissue will not normally contract. The only thing which can contract is myofibroblast. If a new question comes, just think. This might be new for some of you. Only thing here which has the capability to contract is a mesenchymal tissue, which is myofibroblast, right? Perfect. That's myofibroblast is the one which can contract. Yes, option B is the right answer. Rest of them will be there in a scar, but that won't contract. Fine. Okay. Again, a scenario based question. I won't say exactly scenario, little bit of an easy one only. Comment on the right answer. Whatever comes to mind, but give a logical explanation why that's the right answer. Answer. Okay, now let's go to the question. Then we'll go to the options. Fine. We'll read one by one. Again, it's not the goal to give the right answer. The goal is to learn. 51-year-old person tests for hepatitis A antibody. AST levels is 245. ALT level is 310. Both AST ALT level normal value is approximately 40. Let's assume. Fine. 1 month later, the enzyme levels have returned to normal. Perfect. So this patient has an hepatitis. Yes, with involvement of AST and ALT levels elevated, and the patient's hepatitis has come back to normal. What phase of cell cycle best describes hepatocytes 1 month after the infection, right? We'll break the question, we will understand the question, then we'll go to the options. The patient had hepatitis. So can I again help me? In hepatitis, will there be injury to the liver cells? Yes, so it caused injury. Can the liver cell regenerate following an injury? Can liver or hepatocytes come back to normal following injury? Yes, perfect. So it will repair. Obviously, it will repair, right? So the question is after 1 month. Question is after 1 month, right? So after 1 month, it has healed. I know it has healed for the only reason the question only says that the enzymes have come back to normal after 1 month, right? Healed. After a tissue is healed, will there be any active replication or any active division? Yes or no? Will there be any active division? There'll be no active division, right? After 1 month, there'll be no active division. Perfect. Are these statements right? They are right. Right. Let's look at this, right? So G0, G1, S, G2. Of these four phases of cell cycle, which you think is the resting phase or there's no cell division? So we have completed the entire inflammation chapter on YouTube as well as on the essentials batch. Fine. Please go and have a look at it. We'll discuss. Perfect. It is G0. Right. So in other words, how can I answer this question? In other words, is I can answer this theoretically also. I have a group of cell called as stable cells. Can I call hepatocyte as a stable cell? I can. Hepatocyte is a stable cell. All these stable cells, when there is no damage, they will be in resting phase. They'll be in resting phase normally, that is G0 phase. Okay. Whenever there is a damage or an injury, they will definitely come into the cell cycle, right? Every stable cell will be always in the resting phase, right? Let's assume if this question is not about a stable cell, but it is about a labile cell like skin epithelium. Even after 1 month, will the skin epithelium be in resting phase or will it be in cell cycle? What do you think? The skin epithelium will be in a resting phase or in a cell cycle? It will always be in the cell cycle, right? That's what labile cells are made of. Every labile cell, whatever you see, epithelium, GIT, GI epithelium, all the epithelium will always be in the cell cycle and all stable cell will be in the resting phase. A permanently divided cell will completely go out. It will be permanent. It will not be in any of these phases, right? Perfect. Again, one more one-liner. Let's see what will be the right answer. These are simple ones. I'm 100% sure you know this. Ultrastructurally, endothelial cells contain which are the following? Endothelium will never have Langerhans granules or glycogen or kallikrein, right? One of them, this is a finding, it's a one-liner, it's a fact which is seen in endothelium and in Weibel palate bodies. Okay, in Weibel palate bodies, maybe a way to remember P for palate, it has P selectin, and also it has one more thing, one Willebrand factor. Maybe if you want to remember W for W, right? So one Willebrand factor and P selectin are structures seen in your Weibel palate body, and that is obviously seen inside the endothelial cell, right? Okay. Okay, that's a simple one-liner. Fine. Okay, let's go to one more scenario-based question. Okay, this is the last question for today. We'll be done with it. Again, read the question. You need not be always be right. Just comment on the answer, whatever comes to your mind. Okay, Pihu has gone with A directly. Next one. Anyone else? I think A is for the old question, right? I hope so. I want you guys comment on the answer. Comment on the answer, whatever you think is right, and then we'll definitely look at the question step by step as usual. Okay, so let's start with D. Anyone else wants to add to it? Fine. Now let's look at the question superficially. Fine. After 7 days, A section from myocardium is studied under light microscopy must be post MI. Fine. Okay. The microscopic appearance of one of the sections shown below, which of the following mediators is most likely to be expressed to produce this appearance, is actually a patient post MI, post myocardial infarction. After 7 days, I'm taking a biopsy from the heart and I'm seeing the structure. Okay, you're seeing the structure. What are colors you're seeing here? Can anyone tell me what colors are seen here? Just name the colors. That's more than enough. Nothing else required here. What are the colors seen here? You guys are right. Option D is the right answer. We'll see how we derived option D. One obviously is this tiny red ones, right? Perfect. Can I also say I see a tiny blue one here in the corner, or wherever you see blue color, can I say it is seen like a fiber? Perfect. Blood and pinkish background is obviously there, and the blue fiber, right? So this is not a normal HND. This is actually a stain called as Mason's trichrome. Okay? This is a stain called as Mason's trichrome. In Mason's trichrome, it's a stain for collagen. So collagen will be positive and collagen will be blue in color. That's a stain for Mason's trichrome. It's a fiber. So these are all collagen fibers, which is positive in Mason's trichrome. And like you guys exactly said, I have lots of red areas. Red is only one thing in my body, which is blood. That's all right. So I have blood vessel. So in this tissue, I have blood vessel and collagen. Lots of blood vessel, right? I have lots of new angiogenesis, tiny capillaries, and I have collagen that is classically seen in some of you, like some of you said, is seen in a tissue called as granulation tissue. And the main reason for granulation tissue formation is your vascular endothelial growth factor, because like, as you can see, it's a blood vessel, right? So option D is the right answer, vascular endothelial growth factor. So that's about this question, and we'll come to the end of today's discussion, right? Any doubts, do let me know. If not, we'll call it a day. Yes, Vicky, you're right. It's a type 3 collagen. I cannot differentiate type 1, type 3 on a microscopy. I would want protein analysis to differentiate that. Tell me, Lilith, what's the problem? Uh, 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 uh. You saw a real life patient, Lilith, or it's your query? Lilith, if it's a real patient, no, uh, commenting always should be after seeing the patient. Okay. If it's a doubt regarding a subject, yes, I can help, because real life patients, there's lots of variables in a real life patient. You need to inspect. You are in second year MBBS. Inspection is required, palpation is required, history taking is required, auscultation is required, right? So it might be a bit difficult just to tell based on history alone. Might be a heart defect, could be anything under the spectrum. Could be a cardiomyopathy, could be a post MI change, could be a heart failure, could be many things. So if the patient is having a heart disease, your pulmonary hypertension can also cause heart disease, right? So you need a very deep history taking, examination, if required an echocardiogram, and then you can comment on it, right? What are the findings you saw? What are the findings you saw? See, again, cough and cold alone is the finding. Was there breathlessness and cough with sputum production, without sputum production? Cough which part of the day? Morning, night? Cough after an allergy or not after an allergy? See, these are very vague symptoms, right? Cough with fever, without fever, right? If there is sputum, color of sputum, right? There are many things. If all the time, if there is cough and cold, the primary thing will be a chronic lung disorder. That's what I will think of first. Or it could be a heart problem. So that also can result in edema fluid in the lung. You can have a consistent cough. Again, these are two primary things I would think of when all the time you have cough throughout the day. Either a chronic lung disease or heart failure. These are two things. Superficially. Again, I'm just giving a vague differential diagnosis. Lalit, what should you do? If you're in second year, I would say get the help of an intern or a doctor or a PG there and ask them how did they manage the patient. Okay? Because you need to diagnose what is the condition, then only we can investigate if required and treat. Again, Lalit, after stent, no, there are lots of things, Lalit. Everything we cannot have a solution on a chat with few findings, right? If the patient has had a stent surgery and still having a cough and a cold, right? It could be many things. It could be still a stent failure. It could be something unrelated to the heart also, right? So I would say have a detailed examination, then come to a solution. That will be the best for the patient, right? Are you sure? If you're in second year and if you want to have a little bit of insight about medicine and surgery, I would say there is a book called as Hutchison Manual or McLeod. Basic books for examination of medicine, very important, and Das for surgical examination. These two are very, very important for you, right? Okay, try them. Rather than reading a theoretical book now, I would say at least complete the practical manual on examination. That will be enough. Again, you're just giving me one tiny clue for a patient who's underwent a stent surgery. So it is difficult to explain, right? So you will understand the same concern when you come and practice. With a single finding, no one can. You saw the patient, please get the help of the intern or a PG there. They'll definitely help you out. Fine. Okay. Thank you guys. See you in the next class. Till then, bye bye.